Hello, we're talking about cholecystitis and cholelithiasis. Let's get into it. I left off with this particular slide. What diagnostic studies would you expect the healthcare provider to order from AL? So if you're following this out of sequence, this slide does not make sense. You need to watch chapter 1 first, because there's 2 case study slides in chapter 1. So for diagnostic studies, there's a few different things that people can get for diagnosis of gallstones. There's really good ultrasounds. You can have an ERCP, which is it's kind of very similar to an endoscopy. It is an endoscopy where they will put the patient under in a procedural area. Hello, pre-op, post-op slideshows. The patient will go to a procedural area. They'll have a tube down their throat for airway, and then there'll be a camera that's put down into their stomach, and then they'll actually go through the stomach, through the duodenum, and then come up and take a look at the gallbladder. So it'll totally take, well, there's no real direct route to the gallbladder. So that's what we'll do. The camera will go through the esophagus, through the stomach, through the duodenum, and then up the common bile duct and take a peek-see at the gallbladder, and then can go up and take a peek-see at the liver too. You can also do a percutaneous transhepatic cholangiography, which is that's actually taking a look at percutaneous means that they actually go down and to a different procedure lab, and they'll have a little gas put in, and they'll have a laparoscopic procedure. That's what that is. Laboratory tests. People will come back with increased white blood cell count because of inflammation, especially in that gangrenous cholecystitis. They'll have like a wicked bad WBC count. Increased serum bilirubin level because the liver is being impacted about getting rid of bilirubin. Increased urinary bilirubin levels, again, because the kidneys will take over some of the function of the liver when the liver is shut down, and despite the bilirubin just beating the poop out of the nephrons. That's probably not the best way to phrase it, but when I record, I get interesting. There'll be increased serum enzyme levels, and then there'll be increased serum amylase levels as well. So here's our case study again. AL's lab values show an elevated WBC count and a bilirubin count. The provider orders ultrasound, which concerns gallstones, and the client asks what her treatment options are. What are we going to say? Here's what we're going to say. So there's a few different ways that we can go about taking care of cholelithiasis. Cholelithiasis, gallbladder problems are a team effort. This isn't a nursing interventions only situation. So there is a few different things that we can do. We can actually have the client take in medication, and this ursodeoxycholic acid and the chenodeoxycholic acid can be ingested, and they will changes the pH of blood, the liver dissolving gallstones. You can have the client do extracorporeal shockwave lithotripsy, which is that if the stones can't be removed with the endoscope, because when they go up and do that ERCP, they can actually, there's little grabbers at the end of that thing, and they can grab the gallstone and take it out if they want it. If we can't do that, what we can do is we can give them a little bit of shock waves, a little bit of radio waves to break up the gallstones, and then hope that the bile and any sort of oral to solution therapy, the bile acid therapy, can break it up and move it out, and then it'll just be part of the GI system, and then the GI system will pass the gallstone. That lithotripsy, they sit there for about a couple hours, 1 or 2 hours, to get that shockwave therapy. ERCP with sphincterotomy, which is, remember I was trying to draw it with my hands, but here's a nice picture. So with an ERCP, what happens is they have that scope. It goes all the way into the duodenum, and then it goes up into the common bile duct. In this particular picture, here's our stone, but it could find a stone here, or it could find, all sorts of different problems. So we can use the ERCP for visualization. We can actually dilate that common bile duct just a little bit if we need to. We can open it if we need to. And then the stones are removed with a basket. So we can either grab them and take them out when we remove the endoscope, or we can grab them and then deposit them into the duodenum, and then duodenum will pass them with the stool. Here's another thing that we can do. We need to make sure that if they have a cholecystitis infection, we need to do antibiotics. If for whatever reason they're having really bad, severe nausea, vomiting, we can put in an NG tube and hook that up to some intermittent suction so that we can get that, or not intermittent suction, we'll hook it up to suction and get that stuff, the stomach contents out. So then that way the body isn't trying to kick out things through the stomach. You can do if they're doing a cholecystotomy, a removal of that, cholecystectomy is removal. Ostomy is a hole. Otomy is a tube. If we can drain the gallbladder through a tube, and then we're going to be using some opioids for pain control. This is really, really painful, guys. Like I said in the first chapter, people think they're having heart attacks because the pain's so bad. We can also use anticholinergics to decrease those liver secretions, and then it helps counteract those smooth muscle spasms, just to let you know. But more often than not, in my experience, more people have surgery than they have the others. So you can have a lap chole, a laparoscopic cholecystectomy, and you can have an incisional cholecystectomy. More often than not, people are going with the lap chole than they are going with the incision. It really depends upon the patient presentation and how super sick they are. If they're super duper sick, they may do it in incisional cholecystectomy just to be able to have a visualization about what else is going on with the GI system. If they're not super duper like septic sick, like my buddy, my day two patient ever, then they can have a lap chole. Lap choles are incredibly common, and I had one. So lap chole is usually the treatment of choice. And so what happens is there's a few puncture holes, and the puncture holes allow in the abdomen, and in those puncture holes allow they'll blow up a little bit of gas in there, so it allows visualization of the entire GI system. And what will happen is the surgeon can go in and take out the gallstones. They can also choose to take the entire gallbladder. Fun fact, I've been around for a long time without a gallbladder. You don't have to have a gallbladder. And the nice part is I had it as a same-day surgery. It was scheduled. I have been having some chronic problems with it. I went in at 7. I was home by 2. I resumed my normal activities, including work within a week. It was in the middle of the winter, so I would go to the mall and I would walk, and I was back to work within a week and didn't have any complications. Very few people do have complications. This incisional, this open cholecystectomy, they're going to open up that abdomen and they're going to peel back the abdomen flaps, and then they're going to take a look and see what's going on. You can sometimes put a T-tube into that common bile duct, which will make sure it's kind of like a stent sort of situation, make sure that the bile duct stays open, and patency, open, flowing, patent, open. And then it allows that excess bile to drain. So let's say there was excess bile that was built up in the liver because of an acute attack. It would allow that to drain into the duodenum and then be excreted in along with any sort of stool or whatnot. So, quick question. this may come up in class. If you wanted to be a smarty pants in class, you should answer this question now, and then you could just have the answer. Beat it up. You can look super, super smart in front of your classmates. Let's get this. The answer. There we go. So interprofessional care of a biliary catheter, because you can have a biliary catheter too. Remember, I was talking about how there was an otomy and that there was a tube. So we can use this preoperatively, or it can be palliative, because basically what happens is it helps drain that bile out of the system. It's inserted percutaneously and it's attached to a drainage bag. So they'll have, it probably won't like be a direct line, but they'll have a tube coming out of their abdomen that's hooked up to a long line, and they'll be draining bile. There's going to be some fluids lost because of that drainage. So we encourage clients who have this, as long as it's not against other doctors' orders, electrolyte rich drinks such as your Gatorades, Powerades, any sort of electrolyte replacement. If they like pickle juice and you're a pickle juice fan, have them drink pickle juice. And then skin care around that particular site is really important, because we want to minimize the risk for infection. Other intraprofessional care considerations: drug therapy. More often than not, you can get a lot of analgesia. I had never been prescribed so many opioids in my entire life as I've had disc problems. I've nearly broken my ankle. I've done a lot of different things. I've never been given the prescription for opioids that I was given when I had my gallbladder out. So morphine, oxycodones, your opioid analgesics are used a lot because abdominal pain is awful. You can also use anticholinergics such as atropine. Fat-soluble vitamins are really important because these people aren't absorbing their fat, right? They don't have any bile because they have a problem with their bile duct. Fat-soluble vitamins need fat and bile to be absorbed into the GI system. So these people could be vitamin deficient of A, D, E, and K for that simple reason, because there's just not anything going on with that particular digestive part. Bile salts are a common drug therapy as well. Cholecystyrene is can be given to help a lot that GI system as well. Cholecystyrene is comes in a powder form. You drink it. My mom teases that it's her tang. You have to monitor them for side effects. It can cause some nausea, vomiting. It can cause diarrhea or constipation. Okay. It can cause skin reactions, and it's not compatible with some things. So we do need to make sure that it's compatible with the client's current medical regimen. Let's talk about nutrition and then we'll take a break. So for nutritional therapy, especially in that post-operative phase, it'll be small, frequent meals. We don't want to overwhelm that GI system with like a big old meal. It should be a little bit of fat and oil, like no KFC, no McDonald's, no greasy cheeseburgers and French fries. But if for whatever reason they were going to have a salad with dressing, okay. A low in saturated fat, right? Because we want to keep that saturated fat down. We'll want to make sure that it's high in fiber and calcium. So throw some kale in that salad. Yay. And reduce calorie diet if the patient is obese, and avoidance of rapid weight loss. That rapid weight loss really does take a toll on the GI system. And we've just had some major GI impacts from removing that tiny little gallbladder. But it really does change how the client does process things. So we need to make sure that they're losing weight at a, that 1 to 2 pounds a week, sort of, not like 50 pounds in 2 months sort of situation. After a lap chole, they can have liquids the first day and light meals for a few days. After an incisional chole, where they have that split down the middle, once the bowel sounds have returned, that's when they can start liquid diet. I will let you know that the bowels are very, very easy to scare when it comes to surgery. And when they are scared, they don't do nothing. Like fight or flight or freeze, they freeze. So it can take up to, depending upon the extent of the surgery, it can take up to 2 or 3 days for the bowel sounds to return. And a person with an incisional cholecystectomy may need to restrict fats for 4 to 6 weeks, just to let you know. So I'm going to stop sharing and stop recording. I will see you back for some more in just a little bit.